Hi, I'm Adam DeVore, the principal investigator of the CONNECT-HF study. And over the next few slides, I'm going to walk you through the protocol for this study. And I want to just begin by saying thank you. We are very excited about this study and really glad to have you involved. The CONNECT-HF trial is a little different than some other clinical trials that you may have been involved in. This is a large-scale, pragmatic, cluster randomized trial. And the main study purpose is to evaluate a heart failure quality improvement initiative deployed at the health system level. And the goal here is to try to see if we can drive evidence into practice and improve patient outcomes. So a little bit of background. As many of you know, heart failure is very common. This is a slide that shows the current prevalence of heart failure in the United States. Almost 6 million people have heart failure. And over time, that number is expected to increase as the population ages and as more people start to survive from things like heart attacks, congenital heart disease, etc. But unfortunately, the outcomes for patients with heart failure remain poor. As you can see in this slide, on the left are hospitalizations for coronary heart disease, and those have improved over the last few decades. But if you look at the same time period for heart failure, we haven't seen those gains. The reasons for that aren't entirely clear, but one of the things we're hoping to address with this study. And the good news is we have a lot of new treatment options for patients with heart failure. If you look at changes just over the last few decades, we have a number of new medicines, devices, and other treatment strategies for patients with heart failure. But at least in the past, in the field of heart failure and in other areas of medicine, it's taken a very long time to try to incorporate that new evidence into bedside care. This is a very famous statistic from a paper by the Institute of Medicine that shows that it takes an average of 17 years for new evidence to be incorporated into routine care. And even when it is, there's often high variability among patients. Hopefully, we can do better here. And as we start to talk about quality improvement strategies in heart failure, I think it's really important to acknowledge that almost all hospitals have some quality improvement program right now for heart failure. Recent policy changes by the Centers for Medicare and Medicaid have really put an emphasis on 30-day readmission rates for patients with heart failure. And so I think all hospitals are thinking about this. But one thing I hope you learn as we go through the protocol is CONNECT is thinking about this a little bit differently. We want to be thinking about the patient for more than just the first 30 days and really think about the next year of their heart failure care and beyond that. I think one other comment to make about current heart failure quality improvement programs, especially if you think about some of the programs on a professional society level, many of these things live in silos, either in the hospital or in the clinic. And CONNECT is going to try to work differently here to try to address that gap and really think about the whole journey of the patient as they go from the hospital over their next year of care. So let me now go through some of the objectives and then we'll go through some of the nuts and bolts of the protocol. The primary objective of the study is to assess the effect of a customized, multifaceted quality improvement initiative compared with usual care on heart failure outcomes and a composite quality metric score at 1 year after hospital discharge. There are some really important secondary objectives as well. We want to look at the effect of the health system quality improvement program compared with usual care on a discharge quality score for patients being discharged with acute heart failure. We're also going to be collecting healthcare expenditures throughout the study, and we'll be able to look at the effect on resource utilization. A really important part of the study is to look at the impact of a mobile application. And so at some of the sites, we'll be asking patients to download an app onto their phone that's going to use different behavioral economic approaches to assess the impact of the app on medication adherence and other aspects of heart failure care. Shown here are the eligibility criteria for hospitals that are participating in CONNECT-HF. All hospitals have to treat at least 50 patients for acute on chronic heart failure annually, and they have to have the capacity to be randomized to a system-level quality improvement intervention. And so for most hospitals, that means having a team of quality improvement experts. Shown here is the overall study design of CONNECT-HF. We're trying to randomize 160 sites across the U.S. with 7,040 patients. And as you can see in the figure, we're randomizing hospitals to different strategies. So some hospitals will be randomized to the patient-facing digital intervention alone. So for the patients that are interested at those hospitals, they'll be participating through the mobile applications. Some hospitals will be randomized to the health system level direct intervention. Some hospitals will be randomized to both, as shown in the purple, both the digital mobile applications and the health system direct intervention. And then the rest of the sites will be randomized to usual care and will participate through the ConnectHF registry. All patients will have 1 year of follow-up after hospital discharge, and the co-primary endpoints are shown here: time to first readmission or death, and a change in the heart failure quality improvement score that I mentioned earlier. Shown here are the eligibility criteria for all the patients that are included in the registry and the study overall. There are only 4 inclusion and only 4 exclusion criteria, but I want to highlight them here. So all patients need to be adults. The primary reason for hospitalization is acute on chronic heart failure. All patients need to have a left ventricular ejection fraction of 40% or less, and that can be obtained by any recent local measurement. So it doesn't necessarily have to be by echocardiography, it can be by whatever method was last used. All patients need to have a planned discharge to home or some other care facility where they're going to manage their own medications. The point of this is that we want to be able to look at medication adherence, and so we want patients to be responsible for their own medicines wherever they're being discharged. The exclusion criteria include those with a heart transplant or a current or planned LVAD, patients who are receiving chronic dialysis. So that means patients who are on dialysis prior to admission are going to be on dialysis when they leave. Patients who have a life expectancy of less than a year for some reason other than heart failure, and then patients who are unable to participate in the follow-up for any reason. Remember, we're going to be reaching out to these patients with follow-up calls after discharge, and so we need to be able to reach them preferably here in the U.S. after discharge. This is a figure that summarizes the ConnectHF study assessments. And the good news is for the study coordinators that patients are enrolled prior to hospital discharge. There's a baseline exam that includes much of routine care. The patients then have the mobile apps onboarded onto their phone, and then they're discharged. And then as you can see in the figure, the rest of the follow-up is done by the Duke Clinical Research Institute call center, where we're going to reach out to the patient and ask them things like quality of life assessments, changes in medications. We're also going to ask them about any hospitalizations or urgent heart failure visits. And if they have those, we may reach out to you to have you send us records, but you won't have any further contact with the patient as far as the follow-up. We'll take care of the follow-up after they leave the hospital. I do want to make one comment about the baseline visit. So much of the information we're collecting is part of routine care in terms of the physical exam, laboratory assessments that most patients are going to receive as part of their care in the hospital. One thing we want to emphasize, and I'll touch on this again later, is that they need to have an electrocardiogram, and I'll explain why. So I mentioned before that one of the endpoints of the study is change in a score for adherence to the quality of care for heart failure. And if you look at this list, I don't think it's important that we go through all the details, but you'll notice that some of these things we need to know some specifics about the patients. So for example, if you look at the third bullet point, it says we're going to look at anticoagulation use in patients with atrial fibrillation. So we really need to have an electrocardiogram when the patient's in the hospital to know what their discharge rhythm is. The fourth bullet point also talks about indications for cardiac resynchronization therapy. Again, we need to know what the QRS complex looks like so we know if they're eligible or not. All patients that participate in ConnectHF will have the opportunity to download an app onto their phone. For the sites that are randomized to the patient-facing digital intervention, the app will be the HealthStar app. And those hospitals will receive a lot more information about how to download the app on the phone and what the patients will be asked to do throughout the course of the study. Again, as a reminder, if patients are not interested in that part of the study, they can still participate in ConnectHF. For hospitals that get randomized to the health system direct engagement, we're going to want to work with your quality improvement team. Again, hospitals that get randomized to these arms are going to receive a lot more information about all the specifics of that. But you can see some of the details here. We're going to work with hospitals to try to improve their existing quality improvement programs. Just like the hospitals that get randomized to the digital arm, we also have some tools available for these hospitals too. These will all be optional tools available to hospitals in these arms. We're almost at the end of the presentation, but this is a really important figure that I want to highlight. So if you look at the bottom of this figure in green, it outlines that patients that get enrolled in the registry, really regardless of the arm they're randomized to, but will probably be enrolled by a site-based research team, often a cardiovascular or a heart failure research team. We would expect that those are the people who would approach the patients, make sure they're eligible for the study, have the patient sign consent, and then help with the onboarding of the apps. Those are also the people that we'll be reaching out to if we need to get records after the patient leaves the hospital. Separately from the research team, we want to work with the hospital's quality improvement team. So all of the hospitals participating in the study will have a survey for those people to fill out at least twice a year. But in addition, if your hospital gets randomized to the health system direct arm, those are the people we're going to work with. And I like this figure because I think it emphasizes the fact that we expect in most hospitals in the United States that these two offices work separately. They're unlikely to be the same person in both circumstances. I want to highlight all the work that's gone into the study so far and also highlight the important role that you have. So the CONNECT-HF study has been developed by some of our team here at the Duke Clinical Research Institute and also a team of behavioral economists that work at the Center for Advanced Hindsight, also at Duke. A very important role of this study is a steering committee made up of different heart failure and quality improvement leaders in the U.S., as well as a panel of patient representatives. They've called themselves the Cardiacs, and they've had a very important role in the designing of the study and in a lot of the interventions. The last thing I want to say here is how important a role you actually play here. So unlike a traditional drug trial where the intervention just involves the medication, the intervention here is also going to rely on you. And so you're a very important part of this study, and we fully recognize that. So I want to say thank you up front for participating, and we also want to hear your feedback if you're having problems or you have suggestions for improvement. If you have questions or you have comments, please reach out to us. We have a website for this study, and we also have an email address. Thank you.